walk. Where are we now?
C4,
At the level of
C4,
we are moving down. And this is what you're only thyroid gland. Okay? So you're going to place flat fingers, no poking fingers. Okay? Flat fingers on the thyroid gland. And we'll check for the motility. Yeah? So be very, very gentle over here. So the right side goes down the left lobe of the thyroid. The right moves very beautifully down and up, but the left side is slightly frozen. Yes? So we focus on treatment on the left side. So this is about the motility that you feel. The next part that you feel is, what is the size of the lobe? Is it equal on both sides? Yeah? So again on the right side, it feels more flat, yeah? But on the left side, it feels more swollen. So that means the left side is enlarged. Very good. So now we know the motility of the gland. Yeah? So we're going to move the gland, cranial and caudal, to see where is it restricted. Both sides. So moving the gland caudally. Okay, so it goes caudally. Now taking the gland cranially. Okay, so the right side, it moves cranially, the left side doesn't move cranially. So what does it mean? It's stuck down, it's stuck caudally, yeah? So you are, when you're testing, you have this information that why is this gland not moving? What is the cause that, is it the fascia? Then you'll find out later. But just register the information, yeah? So now we know the motility of the organ is also external and internal rotation. So we also check for that rotation on it. So we bring the lobes internally and externally, yeah? So the left side doesn't want to go internal, the right goes. Left side goes very beautifully external, doesn't go internal. Means what? Stuck internally. The right side is okay. So what do we focus here on? The left side of the lobe. Yeah? And that was it.
What was the first thing you checked?
Motility.
This is also the motility you checked. And the earlier was also the motility.
No.
Second was mobility.
Second was mobility, the first.
First was motility.
Motility. And this is also the mobility.
This is the mobility.
Mobility.
I'm moving the structures.
This is also the mobility.
I'm moving the structures, not in terms of motility, but I'm actually moving them. Internal rotation, external rotation is mobility. Motility is the PI.
Yeah.
You're simply placing your hands and listening. What is the body giving me information? Isn't it? That's the motility, right? Great. So we start by checking the PRN. We have the information whether it's the left lobe, right lobe. Whether it's going cranial caudal, the motility will tell you. Whether it's expressing external or internal. You have that information in your mind, registered here. Then we go and check for the mobility. The mobility of both lobes. Whether it's going cranial or caudal. Are they equal or one is lacking behind? No? You have that information. Then you check for the rotation. Whether it's rotating internally, externally. Is it equal or what is it? Is one not moving internally or externally? You register that. And the third one we checked was the size of the lobe. Whether one was bigger, enlarged, normal, reduced in size, whatever it is. You have the information. This is the testing of the thyroid gland. Yeah, we do that, we find out, and then we treat it. Okay?
Yeah, just landmarks. It makes it easy. If you take your hand down, and if you stick your tongue out, what moves is the hyoid. So you know that's the hyoid. You take it down and stick your tongue out. The structure that disappears, that's the hyoid. So you know you're sure. So while you are touching, you've gone there. If you're not sure, okay, which is, some people have a neck like that, how will you know where the C2, C3, C4, C5, C6? So you go there and you say, please take your tongue out. The structure disappears, that's the hyoid. And you go down, ask them to swallow. If something moves up and comes down, that's the thyroid. So you can be sure you are on the thyroid. You can be sure you are on the hyoid with that. Yeah, so that's a confirmatory test for you. Right? As an osteopath, you should know the levels. You go by the level, but you confirm by these tests. Right?
And very important, when you're lying down, the neck is in extension. If it's in flexion, you feel nothing. Yeah? So keep it in slight extension.
Don't have a pillow, basically.
Yeah, don't have a pillow.
You can
Neck
put
should
a
be in
little towel
extension.
or a bed sheet. If for some people who are like that, if you want, just put a little towel or bed sheet. But if you
Behind the neck.
behind the neck.
Are we good to? Okay, so now you're gonna have your own lap partners. You try. If
Still better. The better. Yeah, still.
we're doing the diagnostic testing for the thyroid gland. Yeah. So before we start, so we know the thyroid gland is at level of. Everybody knows that now. Okay. So we go first go and find the C7, the most prominent vertebra. One level up is
C6.
C6. Okay. Samantha. So at the level of SP, spinous process of C6 and the transverse process. Okay, so I have a 3-finger approach here. Okay, I ask, so either you can ask a patient or you can do it yourself. I'm gonna rotate the patient
On the left side.
on the left side, on the right side. I'm going to check which side is it restricted more, yeah? So it's the left furrow, yeah? Now we side bend. So you see, I'm not side bending this, but it's just millimeters, yeah? So I'm at the vertebra checking the rotation and the side bending. On the left, so it's again on the left side. So all the confirmation, whatever we did, confirms the rotation as well and the side bending of the C6 vertebra. Are we clear on this? Yeah? So the next, we're going to check for the lymph nodes along the SCM. So we know the SCM goes all the way down till your
Sternum.
medial. So we're going to check for the lymph nodes. We're going to track the entire SCM and going to feel for the lymph nodes. So I'm on the posterior, I'm on the lateral and the anterior muscle, yeah? So I'm going to move my fingers clockwise, anti-clockwise. And I'm going to track it down, see if I feel a nodule, a swelling or nodule. So it can be a right shape, it can be as big as a hazelnut also, yeah? Depending on what's going on with the immune system. So I'm tracking all the way down. And here I have too many like rice grains, yeah? Do you feel it? So see, many here, yeah? So they're very tiny like rice grains, nodules, yeah? So this is a test and a treatment as well. So when you stay on the nodules for long and you circulate, you're moving it in a circular way, clockwise and anti-clockwise, yeah? You're also melting those tissues, you're melting those fibers there. Yeah? So you keep rotating clockwise and anti-clockwise, and then you might get a listening there because there's a release that is happening. And then you simply follow and then you listen, and the nodule, the rice grain that I was feeling, it melts away.
And be painful.
Was it painful for you?
No, but you have to see, because if a person has a lymph node that's painful, then it will be painful. For some people, the lymph nodes are there and they are not painful. So, and also what structure the lymph node is on. If it is on pressing on something, then that structure might be painful on which the lymph node is there. So it will be different from person to person.
So the shape of the nodule also matters here. So if it's a rice grain type like she had, it could be some food allergy. That is a suggestion. If it's a bean shaped nodule, like you feel it like a bean shape, it's the inflammation. Yeah. So you find out what are you feeling it under your hand. Yeah. So this is how we are treating and also testing for the lymph nodes. So we did the C6, rotation and side bending. Okay. We did the lymph node, and we do one more testing to find out whether it's the vascularization of the thyroid gland which is causing the dysfunction to the thyroid gland. Okay, so we do a right axon test. Yeah. So I'm gonna take. I'm just gonna fix. So it was the left side, so we know it's the left side for her. So we abduct. Okay. So I'm holding on to the radial pulse. Okay, I have the pulse now. I'm gonna abduct. I'm still noticing what's happening to the pulse. Yeah. So the pulse is now rapid. It was okay. Now I'm increasing. Abduction. It's still more rapid. Yeah. And now I'm going external rotation. It's more rapid than before. Yeah? So this is a confirmation that there's something going on. So definitely I check it on both sides. Yeah? So we have information about what is going on this side. Now we check on the other side. Okay. So I'm taking up, I'm still observing the pulse, abduction, abduction, abduction. Okay, the pulse is normal throughout. It was rapidly increasing on the left side, here it's completely normal. I externally rotate, and it's still normal. So that means what? Everything is okay when it comes to the vascularization of the thyroid gland. Okay? Are we clear on this?
You should remember that you should always do this test before starting to treat
Yes.
any arteries along the pulse.
So Ankita did mention about the observation, the history and everything, yeah? And the person comes to you. But if you have to first go and treat, you have to do the testing before. So the one that we did was, this step is one way before the one that we did before. This is the first step. The previous that we did was the second step. So we start by checking the C6, feeling for the lymph nodes, and the axon joint test to see if the thyroid gland is affected through the arteries. The arteries are the cause for the dysfunction of the thyroid gland. Okay?
If the pulse increases, it denotes that the arteries are the cause.
So there's a change. What we are looking for is a change. It can be rapid, it can be feeble, anything. So your everything was normal. So on the affected side, either the pulse can be rapid or feeble. So we're looking for change of pulse.
That signifies that has it affects
The problem comes from the artery.
How do we know that the change of that pulse is because of thyroid and not because of any other structure in the
Like break the blood vessel.
no, like it's for the thyroid only, not for the any other thing in the chest or
No, but you have to do the test to make sure that K1 is okay and
So this test is for the vascularization of the thyroid gland, but of course you also test all the structures. This is just one of those, like a confirmation to your PRM, your mobility, everything that you were doing is one more test of a confirmation.
His question is that how do you know that the test for the blood vessel that we did, it is for thyroid only and not for anything else? Meaning it can be for anything else.
Also,
this
but
is what we said.
But the vascularization of it comes from the circulating artery, it goes to the axillary artery, it goes to the brachial artery, and all the way down to the carpal tunnel. Yeah? So more likely, it's for the thyroid. Yeah? Of course can be anything else also. Yeah?
Even laryngitis you will find that. So it can be for any other structure also. But if your thyroid is one big structure, and when you are checking for the thyroid, you check. So they overlap. See the blood supply, nerve supply, lymph supply, they just overlap. Always.
So when we're checking, we are seeing it's getting rapid or fever. So why does it happen? Is it because there is more swelling on that side? That's why the artery.
It's the pressure gradient. Pressure gradient. See there is pressure in the artery, right? That's the difference between artery and vein. The artery is the blood. How you check the blood pressure on the artery? Lateral pressure exerted by the wall on the wall of the artery, right? So when you are moving with gravity, with the structure, with the breath, the pressure gradient changes. So this is why you are doing it with a motion. So with the motion, is there any effect? If she holds it there, it's not going to stay like tuk 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 for me. I don't have atrial fibrillation or flutter. Are you getting it? But it will come down. If she just takes it there and holds it for a bit, it's not going to stay fast or slow or anything. But at that time, there is a change that I noticed. Meaning it changed and then it became the same again. So that is more to see that, okay, with changes in pressure, with position, there is something that can affect. So maybe there is some tightness, maybe there is some swelling, maybe there is just some little tension that it feels, and then it says, oh, not a big deal, and it comes back to normal. But there's something around that area which can change the pressure gradient of the system.
Can it happen that we are doing a series of tests for the thyroid now? That more than one compound.
CSF test.
No, it is a
Series of
tests that we're doing for the thyroid now. That more than one or two components are affected.
Yes.
Of course.
Overlapping. Always remember, no system works alone in the body. And you remember Andrew Taylor Still's 5 principles, no? Role of the artery is supreme.
Okay, come on, practice.
So there are 3 levels of palpation here. The first level of palpation is where you're just feeling for the pulse. That's a diagnostic tool. Whether the pulse is feeble, weaker on one side, or is it rapid on one side. So you now feel for both the pulses. Yeah? Pulse. So we have the SCM, going all the way, and medial to the SCM is we have the common carotid pulse. Yeah? So I'm going to feel for the pulse, and it's a bigger pulse, so you really feel it. You cannot miss feeling it.
One at a time.
Yeah. You can also do one at a time. Yes. So more rapid on the right side. And slightly feeble on the left side. Yeah? So it also confirms about whatever we tested for. It is also one more level of confirmation. Yeah? So now, this is a diagnostic tool where we are just feeling the pulse. When the treatment starts, you're going to go inside the artery. You're not on the superficial rami of the artery, but you're going to press the artery little bit. Yeah?
Going just with the intention, we are also going
We're going inside the artery. Yeah? And from this level, I'm going to feel whether the artery is going caudal, whether it wants to go caudal, whether it wants to go cranial. I'm also going to check for lateral and medial. Yeah? Now the third level of palpation we do not want to do is the force. We do not want to press onto the artery and make her regret the course. Okay? So the first layer was palpation without having any force. So we are very superficial, feeling for the pulse. The second layer is you put slight pressure, you are inside the artery, you're feeling and you're listening, whether it's going cranial, caudal, lateral, medial. Yeah? So So for her, the right is beautifully going in all directions, the left side is not. So we know the carotid sheath is restricted on the left side. Yeah? So the treatment starts at the level of second, which is your flow. So when you are in the artery, the circulation flows and you want to feel for that flow. Yeah? So all the treatments that we do it on the second level of palpation, which is the flow. The first level was the pulse, to just feel for the pulse of the artery. The second is the treatment, the third we do not. Okay, we do not put any force.
So don't block the artery.
And arteries, they love elongation. Okay, they do not like compression. So we're not going to compress, but we're going to elongate. And that eventually happens when you're doing some listening, the stretch automatically happens. Yeah? So we try the small one thing. Just have the feel of the artery, have the feel of the pulse on both sides. Feel the pressure. You're pressing towards what's happening. Is it same on one side or a different one? Whether it's going on here, have the feel of the artery now, okay? And then later we started the treatment. Okay? We are not doing any treatments, only testing.
And testing is also only one at a time on one side.
One at a time. Yeah, but you compare left and right, you compare the artery. Medial side is the common carotid artery. Okay? And now I'm only superficial because I feel the pulse. You do not have to press because it's a big artery.
Person can get a
DC.
Yeah. Okay? So I am superficial on the pulse and I feel the pulse of the artery. Now I slightly go deeper and I'm inside the artery. Okay? And I'm going to feel whether the artery goes caudal, radial, whether it's going to medial or lateral. So I don't feel anything on the left side because it is restricted, but I feel it more on the right side. So we're just having a sense of palpation to our hands before we go for the treatment.
But I have a question. Is it necessary that everything we will found only on the left side? It could be on the other side as well.
It can be on the
It
right
can be on the right side because we have so many organs. We have so many. There's a lot of fascia connections to different shoulder, liver, lungs, everywhere. Yeah. So this is just feeling how to feel the pulse of the artery, how to feel the structure of the artery before we go for the treatment.
Like for her, everything we found
Could not be
it was
the
supposed
same
to
for
be
the
everything
others.
that came out was on the left side only.
Yeah.
But that is not the possibility with every case. You know,
Obviously,
it can
there
be.
was
No, some of them it's like right side.
different. Yeah. That's what.
You said there are 3 levels. What is the total?
There is a picture.
मतलब कि superficial, just medial inside, and then you go in and you like press when you how you
But we
go to
didn't
the
show
pulse.
that, right?
No, we don't do that. It's telling you don't need to do that. Like when even when you go, you go different levels. So like
So you
this
don't
pulse
do
you can
that.
go 7
You do
levels,
not-
right?
You
So
do
it's
not
more like
compress on the artery. Yeah? Okay.
Is there any other
What
precise
else do you
test?
want? We have checked the lobe. No, we have really moved the thyroid. We have checked the PRM, and I think that is good enough for a nostoplasty.
You have something in your mind?
By working on the carotid sheath, so who can tell me what is inside the carotid sheath? Which 3 vessels? Jugular vein,
And biggest
and
biggest flow.
veins. Okay, so today we palpate, we find out, and we test the sheath before we start working on the common carotid artery. Yeah, so we need to release the sheath before, right? Yeah. Okay. So I'll first show you the muscles that surround the triangle that surrounds the carotid sheath. Yeah. So the first muscle is what? What is this?
SCM.
SCM, which is very much evident over here. Okay. Then comes the digastric muscle, the belly of the digastric, and we have the omohyoid all the way going to the suprascapular notch. Yeah? So this is the triangle we are interested in. So we have the medial border of the SCM, and now I'll sit here. Okay. Is it okay if I come slightly?
I was following this.
Okay. So we have the SCM here, and medial to the SCM is what? Carotid, yeah, carotid artery. So I'm grabbing the sheet with 2 fingers, yeah. We are not working inside, but we are on the superficial. We are on the sheet, yeah. Okay. So I'm grabbing with 2 fingers, and I'm going to glide the sheet, caudal, whether I'm testing whether it's going caudal, cranial, medial, lateral. So in this case, it's restricted caudally. Yeah, there's something pulling caudally. Now we have that, so there's some tension coming from caudal. So we test all the way down, yeah, throughout, from up. Yeah, it's still caudal tension. Yeah? You could feel it. It can easily go up. It cannot slide it down. Yeah, easy, medial, lateral, slightly difficult. Yeah, so it's caudal and lateral for her. Yeah, still caudal. Yeah. Okay. So now I have the information of the restriction, in which is it cranial, caudal, medial, lateral. Now again, I hold the same area. So I'm going to be much more precise on this. So I'm feeling for which area is the one that is dragging me, the area of restriction that I, and the listening that I feel. So when I come much more lower, and that's where I feel the pull is coming from. Yeah. So I take the sheet towards ease, where the restriction is. Yeah. Yeah. So I can take it either upwards towards ease or where the restriction is. But in her case, it wants me to go caudal. So I simply go caudal there. I wait, and I immediately get listening because I am on the sheet. So the listening may really, you have to move along the way it is taking you along the restriction. It is all the way going down. So you follow the listening. You wait there. You let the vessels, you let the sheet melt under your fingers. And there's a sense of like, it has calmed down. Everything has just stretched and relaxed. Initially it was like, there's something which was like pulling, a stretch, and now when we follow, everything just melts away. That is the kind of a feeling I feel under my fingers. Yeah. So is it clear what are we doing?
Yes.
Yeah. We are finding we are on the sheet. We are not going on the second layer. Yeah. We are on the sheet. Yeah. We are going to track the sheet from up, cranial, caudal, medial, lateral. Okay, this is okay. I move one level down. Cranial, caudal, medial, lateral. This is where I feel that it's pulling me caudally much more. I go to the point of precision where I feel there is maximum tension. I go there, and as I reach that layer of sheet, it gives me a listening. So you listen and follow, and there your treatment starts. So testing goes into treatment. Simple, clear. We
Can
do
we
this?
do for low BP patient? Lower, if the person is having low blood pressure.
So we're not pressing on the arteries.
We are superficial. We are not yet on the common carotid. We are on the carotid sheath. You get it? Yeah. Do you need a picture?
Are you also applying some pressure? Like
There is no pressure.
Very subtle.
It's not subtle, but I am on the sheet gliding. Yeah.
It's not down, it's sideways.
So if this is a sheet, yeah, I am on this layer. I am not pressing on the sheet. I am gliding. I'm gliding on the sheet and listening. Do you understand? So of course, when you're not feeling anything, raise your hand and we'll be there and it'll make you feel. Yeah? Clear? Can we start?
We have to elongate like you told yesterday.
So, listening, when you are on the structure, it may give you a listening, and that listening results into elongation, a stretch, and then it relaxes. But you are not doing any stretch induction here. It leads to elongation by itself. Yeah? Okay. That we did for the vascular test, the vascularization of the thyroid axon. So that is a general indication telling that there's something going on either on the left side or the right side. Now we do a local testing. Yeah? So to give you an anatomy correlation of why are we testing the supraorbital and the supratracheal. So the carotid artery divides above the hyoid into two. The external, which is much more anterior, internal, which is deeper. So it's difficult to feel the internal branch of the carotid artery. It goes all the way inside the brain, comes out through the ophthalmic branch of the artery, and then it comes out in the supratracheal foramen. From the notch, we can feel the artery, and the supraorbital foramen, we feel the artery. So before treating on the carotid artery, we work on the pulse and we release this. We remove the pressure from the brain, from the skull, before working on the carotid artery. Is it clear? Do you understand?
How does releasing here release the pressure?
Okay. So we feel the trochlear foramen first. There's a notch here. And you feel the pulse just above the notch. It's a very thin, it's a very thin artery, not thick, not a strong pulse as a carotid. Okay? So one hand on the supratracheal and the other one on the supraorbital. Okay? And I feel for the pulse, whether it's giving a feeble pulse or a strong pulse to my I compare on both sides. Okay? Supratracheal, supraorbital. Okay? So for her, she's normal. I don't feel any strong or feeble pulse. Okay? But in those cases where there's a lot of pressure inside the brain, you will definitely feel that you feel a feeble pulse and you treat that part of the artery. Okay, you get it? So how to treat this artery? So you have to find whether the left or the right side first. Yeah. In that case, we take the left side. Now I'm on the supratracheal, supraorbital pulse here. I'm feeling. So I feel the tension is more in the supratracheal. Okay. So I'll be on the supratracheal artery. As soon as I'm in the area of restriction, on that pulse, I feel the pull is really coming from inside. Yeah. When I feel that pull, there is this thing that happens. You listen and follow, and the artery will really start moving. As you just did it for the carotid, the sheet, yeah? It will be the same. And you release that, yeah? Release the artery, and that side is the one which we treat the carotid artery to, because it's connected to the internal and the external branch, and we treat the carotid artery. So this is a test and a treatment for the internal carotid artery branches. Yeah, because we cannot treat the internal carotid because it's very deep. Yeah? And that's also an indication that that side of the carotid artery could have tension or restriction. Yeah? And with whatever the test that we did from yesterday also gives you, everything confirms that this is the lobe of the thyroid gland that could be restricted in dysfunction. It could be the artery, and we have a double confirmation now. Do you understand? Are we okay?
Do we also release the thoracic inlet first?
We come to that later. There's a lot of fascia later work that we do. Okay, so this was the testing. Are we clear with the test?
Can you repeat just the steps of the test?
Yes.
Without showing, just the steps.
So the first, we find the pulse. This is
Supratracheal.
supraorbital. Above the orbit, supraorbital. You actually feel for the foramen. There's a notch here. You just don't place your hand anywhere. Yes. And this is the trochlea. Yeah. So you move. You can really feel the notch. You can the foramen over there. Okay? And now you are on this and you're just feeling for the pulse on both sides. Which one is weaker? That's a test, a confirmation which side to treat. Okay? Now we come on the treatment. Yeah? So, for her example, if it's a left side, yeah, so we have known how to find the artery. So this is a SCM. You confirm it's the SCM. The border over here, yeah, you feel it. So you go all the way down. Okay, so I'm really walking down, yeah, the muscle over here. I go all the way down here. Okay, and I feel a pulse immediately. I do not have to go with my lens. No, it's very obvious. You go to the medial border, you have the pulse over there. Okay, so we are going to treat the artery at 3 levels. The inferior level, yeah, and we trace it up, we follow the pulse, and we reach the middle part of the thyroid artery. So you're releasing the inferior part and the medial part at the same time. So how do you release? Now in this level, do you remember the 3 layers of palpation for the artery? What is the first one? The superficial was for the testing. So now we're doing the treatment. So at which level are we? The second level, which is at the flow. So we are not on the periphery of the artery, but we are inside the artery. So inside the artery, you feel the flow of the circulation. Right? So when I'm inside the artery and I feel the flow, it wants me to take down. So you do not use your mind whether I go cranial, caudal. As soon as you are in the artery, it will take you, there will be a listening. You simply follow your listening. It will track you down all the way down to where the artery goes. Yeah? You listen, and it's not necessary, it will only take you down. After, so in her case, it took me down and it is taking me upwards now. So what is the point? We treat the upper part. We track the artery, we go to the superior part of the artery in relation with the medial part, the middle part of the artery. Yeah? So we connect the 2 arteries, we are inside, so we wait, we come from the superficial part, we are now inside the artery. I feel the flow. When I feel the flow, it takes me upwards because we have already released the lower part. It takes me upward, I simply follow. So see, my body also moves with it because I'm inside the artery. Now I am the artery. So I am moving as the artery wants me to move. Yeah? And then it releases and there's a harmony. I don't feel any pull coming from inferior, cranial or caudal. Very simple. You've already done it. So I'm clear with this.
Can you still hold it?
Let me approach the external side. So here we are working on the common carotid artery. It branches out into external, internal. We are not treating that. We treat that along with the facial artery later. So this is what? Common carotid. We are not treating external. Okay? So
Right now we'll first go for this one.
yeah, we are doing the testing to find the pressure. If there's pressure inside the artery, that gives us an indication which artery to treat.
We don't treat this part. Do we treat it?
You can, in the normal circumstances, definitely you can. But now we do not have much of a time. We directly go for the artery. Come on. Okay, so I'm just feeling for the pulse to find out which one I treat.
Ma'am, I have a question. If the sheath is restricted, shouldn't the pulse be shouldn't it be rapid? And should we treat the rapid area?
So there was one question that came to me. We treat the pulse, which is either more rapid, means there is a restriction, or it's feeble. We do not treat the normal pulse. Yeah. So that's how we decide. So it can be feeble or rapid depending on what the restriction comes from the brain or it's coming from any pull from downwards from the organs. Yeah. So we don't want to treat, of course, the normal artery. So there will be always, and there could be a chance where it shows that the left is feeble and the right is more rapid. Now, which one to treat? So So that's why we are doing so many tests to find out the motility, the orbital test, the right axis test, which is the one that gives me more confirmation. And then we treat.
I have a question. Cat did we blocked on the both sides or have coiled on both
Of
sides?
course, yes. Of course, yes.
This is only for the practice that we're treating the
Yes.
nerves.
Yeah. Okay. So, in a case I decide to treat the left because that's what I found. So I'm on the side first. Okay. So how do we find the thyroid cartilage and the gland? We walk.
Sir,
We walk from the thyroid. Yeah. So I'm on the thyroid. How do I know? I move the thyroid side to side. Yeah? It's a bone. We can move it. Yeah. I walk. I'm on the cartilage. I move for the cartilage side to side. It's a confirmation I'm on the cartilage. I walk. I'm on the gland. It doesn't feel bony to me. That means I'm on the thyroid gland. Yeah. So now I place my fingers on the thyroid gland and the lower part of the cartilage. Okay. So this is the cartilage. Yeah. So till here is the cartilage, the bony structure that I feel. So I place 3 fingers. Because the artery goes like this, it also goes in the lower part of the cartilage. So we do not want to miss anything. Okay? Now I am feeling again the SCM, medial border, I'm on the artery, I feel the pulse. Okay? Now I am on the superior thyroid artery, I feel a pulse in this finger. That's why we place 3 fingers. Yeah? Because at any of the finger you can feel it. And you really feel the pulse. Okay? Do you feel the pulse? Yeah? So I'm on the superior thyroid artery with my ring finger here. Yeah? Now here, the CM, common carotid. And now I'm going to go inside the common carotid artery. We are on the second layer of feeling on the floor. And when I feel it, I want to feel where does the artery now. And 80% of the time, it goes cranial because there's some tension coming from the cranium. Okay, and in the case also it goes cranial. So now I'm going to stretch. Stretch induction is a technique that we do. We are going to stretch the common carotid cranial. We are listening. We are not doing a manual stretch. Huh? We are listening. We are following the artery wants to go up, and the superior thyroid wants to go medial in the flow of the direction of the artery. So see, they are going in the opposite direction of the head. And we are not doing a manual stretch. We are osteopaths. We listen to the artery. We follow. And there's a listening, and there might be a torsion in a case where it is. We follow. And now they want to come together. Yeah, they're hugging each other. We follow. And there's a separation, there's a release. Yeah? It really takes like 5-10 seconds. Yeah? If you're really in the structure, it's a quick release. Yeah? How do you feel? Something release. Yeah? Because this tension was coming from cranial. There's some restriction. When we release it, all the digastric muscle, everything just loses. Simple? Can we do it? Okay. The medial artery will definitely go medial because it's in that direction of the line of the artery. And then we listen and we give a stretch. We do not do any mechanical stretch. Yeah?
So first we'll do that listening stretch, then we come together.
So whatever technique that I did today, it was her artery that made me do. For you, you can feel it other way. It can go caudal, it can be a torsion.
Okay.
You listen and follow.
Okay.
Yeah?
Yeah.
Because in order to release this inferior thyroid artery, you need to also work on the subclavian artery. Yeah? So we release the subclavian artery and then work on the inferior thyroid artery. Okay? So what I want you to be sidelined.
Right or left?
Yes, okay, go. So in order to feel the subclavian, my hands, they go underneath, yeah? So let's find the clavicle. Am I on the clavicle? Okay.
We should go on the other side. We should go to the other side.
Are you able to see from here? No. No. Yeah?
No, we can't see. Can you make a bigger circle?
Yes. Big circle.
Okay, so I'm on the clavicle now, but the artery is deep inside. Yeah? So we have to place the shoulder in such a way that we can feel the artery. So we're going to move the shoulder crane. Yeah? So now I have a groove, isn't it? I have a groove, and I'm going to take the shoulder anterior. So now I'm inside the clavicle. Okay? I'm inside the clavicle. I'm going to feel for a pulse now. Okay, so I'm still placing my anterior cranial. I'm inside, and there is where I have the pulse. So subclavian artery is a big pulse like the common carotid. It's easy to find. You just have to place the position cranial, anterior towards the bed, and the pulse comes to your hand. Okay? Now in this treatment of treating the subclavian artery, we do the sweep induction technique. Okay? So in the sweep induction technique, we are not going to do stretching. We are on the superficial lamina of the artery. So the artery has the outer muscle, the smooth muscle, and the elastic deeper layer. Yeah? So we are going to affect on the elastic layer. The treatment works on the elastic layer by doing the sweep induction technique. So why do we choose this technique? So if somebody has like microcalcification, like you must have felt that when you were palpating, there was some part that felt smooth. There was some part that felt slightly swollen, thickened, So when the artery is in a lot of irritation, there's so much of sensitivity, the artery thickens and there can be microcalcification. So this is the time when you use this technique. You will not do stretch induction because it's already irritated. You don't want to irritate more by doing the stretch induction. So you're going to do sweep induction. And how do you do this technique? So I'm going to just show it on the hand. What am I doing here? Because it might not be visible. What am I doing here? So this is the artery here. My hands are not inside the artery. I'm on the elastic layer of the artery. So we'll show you on the picture what do I mean by the elastic layer. Yeah? I'm on the artery on the elastic layer and I'm going to just give strokes. I'm going to stroke the artery, gentle stroking of the artery. Yeah? So I'm on the artery here. I'm going to just caress the artery. Means what? I'm going to give gentle strokes. Okay, in this manner. I'm going towards the direction of the shoulder because there's a curvature of the artery. The subclavian artery goes into axillary artery, brachial artery, medial and ulnar and the radial artery. Yeah? So the upper hand is on the shoulder. So let me bring it back. Upper hand on the shoulder. I'm in the clavicle. I want to go deep now. How do I go deep? Radial, anterior. Now I'm inside. I have safe space. Now I'll wait for the pulse. I have the pulse now because it's a weak pulse. Yeah? Now I have the pulse and I'm simply going to stroke. I'm gently stroking the artery superficial. I'm not inside the artery. I'm superficial. Yeah? And I'm giving strokes. Yeah? I'm increasing the circulation in this direction. In the direction of the artery. Okay? And I improve the circulation. Okay? So while I'm giving the sweep induction, while I'm stroking, I get a listening. What do? I listen and follow along the artery. Okay? And the shoulder might start moving because the subclavian artery goes forward into axillary artery. Yeah? So as I'm doing the treatment, there's a listening and I just listen and follow. Okay, then I don't do the sweep induction because I've already got the listening, isn't it? Okay, and when the listening stops, yeah, when the shoulder may move, may not move, yeah, it depends, yeah. There's still a listening, I am still on the artery and I'm just following. And it is actually taking me all the way down, yeah. So see, my body is also moving because I am the artery now. Yeah? It's taking me up, it's taking me down, anterior, and there is still a release going on. So it might take a while because shoulders are so important. This artery is very important. Yeah? So it's still releasing. You immediately get a listening when you do good strokes. And I'm following with my body, yeah, because I'm feeling it. So I feel the elongation of the artery, and that's it. We stop. Now the artery is relaxed. Yeah? How does it feel?
Very good. Very relaxed.
You also felt something going all the way into your hands, yeah? So even though we are working on the subclavian, but we are affecting the whole arm. We're working on the whole arm. Yeah? Clear? Yes, yes, yes. I want you to lie straight facing. So now we did what? The subclavian. And now we're going to work on the inferior thyroid artery. Yeah? Yeah, can you move backwards a bit so that everybody can see us? So we know the position of subclavian artery. So I'm going to just, find a comfortable groove until I feel the pulse, and I already have the pulse. Please understand why I did what I did? Yeah. Okay. Now we know the borders of the inferior thyroid. What were the borders that I just explained? Common carotid, subclavian, and that's how we find. So we know SCM. Yeah. And I have the pulse. Okay, so I have two big pulses. I have two big pulses and then my fingers. So I know the artery is somewhere in between. Okay, I have two big pulses under my fingers. So I'm going to place my finger now in this manner. The curve, like the angle. Yeah? And I'm going to just wait because it's a deep artery. I'm going to wait and sink into the layers. I'm not going to penetrate or push or no. I'm going to wait. I wait. I sink in, and the pulse comes to my head. Very simple. It's a thin artery, it's deep, but you simply have to wait for the tissues to melt. And when the body allows you, it's comfortable, it gives you the pulse. Very, very simple. You have the subclavian here. You already have felt the common carotid. You place 2 fingers or 3 according to your, the size of the neck, and you wait. You wait, you sink in, and you feel the pulse. Okay. Now, you feel the pulse. Yeah? Okay. So I'm on the inferior thyroid artery now. So what am I going to do? I'm going to do the stretch induction. So now I'm going inside which artery? Subclavian artery, because it's a big pulse. Yeah? So I'm going to go inside the subclavian artery, very, very gentle. Let the body allow. Yeah? I do not force. I go inside and there's a listening. Yeah? So what do? The inferior pulse that I have, inferior thyroid artery, is taking me upwards along that curvature here. And the subclavian artery wants to go down. So you see what is happening? Subclavian artery and the pulse of the inferior, they want to go like this. There's a stretch that is happening in this direction, but you might also feel it in this direction, according to what's going on in the body. Yeah, so you follow the same principle. Get inside the bigger pulse. So you already have the subclavian artery. Get inside. There will be a listening. You follow the listening, and it will always follow the artery direction. So it is going towards the shoulder. Most of the time, it will go towards the shoulder. You follow the pulse. You're listening in this direction. Now the curvature of the artery might take you towards common carotid or towards the subclavian. Yeah? You listen, follow, release, as you did previously. Simple.
Please show the hand position on this side.
Can you come this side real quick? Okay. So I'm on the collective. Now I have to make way, yeah? So I'm going to move up and down. See, now it's deeper. I can go more deeper now, yeah? And I feel a pulse, very simple. Yeah? It's a big pulse. Now, the common carotid, yeah? There's a pulse there. So now this is the angle. My fingers are going to be in between there. So now I wait for the tissues to melt, sink in, and I get a pulse. I mean, it's no big deal. You would really get the pulse because the artery is there, yeah? And now I'm going inside which artery? Subclavian artery, yeah? When I go inside the artery on the second layer of palpation, I have a listening which wants to go this way, along the direction of the artery, yeah? And this side, the inferior thyroid artery, wants to go upwards. So most of the time they will separate. They'll be in opposite direction, but as you listen and follow, they might come together, hug each other, talking, whatever the dance they want to do, they will do it. And when you have, everything relaxes under your fingers, there is calmness, there is no movement, and there's a feeling of elongation, stretch, everything melts under your fingers, you're done with the treatment. Good? Artery. Why we do it? There could be subcalcification, thickening of the artery. So we do not do stretch induction in such cases. We do the sweep induction. Yeah? Okay, so we move on to the next, thyroid, and Ankita will take it on.
So what we'll do now is there's another artery that will be done in a while, the laryngeal, but it is underneath the hyoid and it's a little at the deeper level. So if the structures above are released first, it makes it easier for us to approach and go there without much difficulty. So what we will do,
This is the hyoid bone that we all are familiar with. And this structure here is the superior laryngeal artery. So in order to work on the artery, we have to release the hyoid bone first. So that's what we do, okay?
So what we'll do is we'll do two techniques. These are called functional technique. So functional technique is the same for the whole body. If you learn it for one part, you can do it for any part of the body. You've learned the functional technique? Yeah.
On the thyroid bone and on the thyroid also?
On the thyroid you've learned. No? So the same thing we'll do with the thyroid. So you move the whatever organ or structure you have in basically whatever plane your body allows. Usually we go in 3 directions. So for the thyroid specifically, it will be above and below, like you go cranially and you go bodily. You go side to side, which is a lateral translation, and again side to side, but in a rotatory movement. So there are 2 schools of thought. Some say that you go in the restriction, some say you go in the ease. But a lot of people believe that if there is a restriction and you go more in the restriction, the structure doesn't like it. So it's nicer and easier if we go in the direction of ease. We do it with the breath of the person we are working on. So it's even more easier because breath out, incoming breath is for energizing, outgoing is for relaxing the body. Right? Outgoing breath is the breath of the parasympathetic nervous system. You blow, right? For relaxing. So when we go with the breath out in the direction of ease, in all the 3 planes combined, it releases the tension in and around the structure. So you also release the surrounding structures that are there. So that's what we'll do. We'll just practice once with the hyoid, you already know, and with the thyroid. We'll release both, one after the other of course. And after that, we work on the other deeper layer structures. So we'll go to the table and see it once. Yeah. Part with the functional technique is you can teach your client to do this on their own. You know, sometimes when we give them certain things to practice at home, we empower them to take charge of their body rather than they coming back to us again and again for a release. So we can do it for them and then we can teach it that you can do it on your own at home also. So for the hyoid, again, why don't you sit? For the hyoid, it's better to do sitting than lying down in general because the grip of the hyoid is better in sitting position. So yeah, so I'll go on the side. So you can come this side.
On the
all
side,
of you.
move there. How you want to
Yeah.
sit because you can be at the border of the table.
Yes. I think that's okay. So basically, I want to use my first 2 fingers. I want to use my first 2 fingers to get to the hyoid. Okay. So usually when a person is sitting where your transverse, the horizontal part of your under chin and the neck where they meet, you will have the hyoid there. Okay. So it's a good idea to support them from behind. I'm not pressing or anything. I'm just putting my hand. So they don't have a tendency of holding there because when you hold, they'll be like that. So when I do this, they get a little relaxed. So this hand doesn't have any purpose, but it's just more for them to relax. So usually just create a rapport with your hand. You've touched there, you've touched, and then okay, I'll be touching your neck region. Is that okay? So we go there. So you just relax. See, you saw before I got my hand, she does that. So if you give this, she'll be a little more relaxed. Okay. So I go down, I find my hyoid. We can always ask her, can you stick your tongue out for me? Yeah, it disappears and you can close your mouth. So I know I am on the hyoid. So what I want to do, I want to go left and right. So I am just doing a translation movement, not rotatory. These are 2 different things. So left, right. I feel it's easier to bring it towards me. It doesn't matter left, right. Like this is easier to me. So I remember this is easy. Okay. Then I check a little up, down. I feel up is easier for me. So up and towards me is easy. And now I do a rotation. I feel the rotation like that is easier for me. So this and this, right? Now we do it with the breath. So we will combine all the 3 easy movements. It's a good idea. So if you give me your notebook and the pen, so it's very easy to forget. So I know towards me was easy. Okay. Rotation was easy other side, and up and down what was easy? Up was easy. So I know this. So you know I can keep these arrows. So I don't have to remember while I am doing. Oh, what was it? Was it there? Was it there? We tend to forget. So you can have the arrows near you somewhere. So I can see it and do. Just relax. My hands are there very gently. I am not even like holding any this thing. So just relax. Just relax. Yeah. Now
This is not relaxed.
I ask her to breathe in and breathe out. Yeah. So you breathe in, and as you breathe out, I will go here, up, and rotation. Did you see that? Again a breath in and breathe out. More here, up, rotate. From where I was. I am not coming back to the center. Once again, breathe in. As she breathes out towards me, up and rotation. By this time, I am actually feeling tension in the structure because I have gone a little more than the range. And I stay there and I tell her, just relax. Yeah. And then I release, and then I just keep my hand there and I follow the unwinding of the fascia. So wherever it wants to go, however it wants to move, you move your hand around. Okay?
Every time during the breathe out, we have to go further.
During the breathe out, you go in the direction of ease. It works better like that. And then, say for a minute or so, you move it around and you stay there. If you want, you can check again. And if you find still some restriction is there, both are not equal, you can repeat the technique. Usually, in 3 or 4 reps, it goes. Yes.
Is it not that we take the bone in the direction in the breath which is easy for the patient?
So usually out breath is the breath of the parasympathetic. By physiologically, incoming breath is the breath of sympathetic nervous system and outgoing is the breath of parasympathetic. So parasympathetic will be easy for the body, for the nervous system. Might not be for the person sometimes, but definitely for the parasympathetic nervous, for the nervous system, it's the because you are relaxing, you go by the relaxing breath.
Also the passive breath. No, it's not. Expiration is always passive.
Okay, so the same thing for the thyroid, yeah. So you go down, you have the thyroid inside the sternocleidomastoid. You can feel the medial border, walk up, feel the medial border, walk up, and you are at the thyroid. Again, no pressing, you feel, which is easy. So usually I don't like to press and move it because they feel a pinching. I like to, when I am pushing that side from the thumb, my hand is kind of away from the gland. Again, like that. So I feel coming towards me is easy. So same thing. So coming towards me is easy. Then this one down, going down is easy. So it's opposite of the hyoid, it's not the same. And rotation also towards me is easy. So I support her, relax her, and now what you do is just breathe in. As she breathes out towards me, rotation and down. There is no order of these 3. Basically all 3 you have to do. Now I hold it here, breathe in, as you breathe out, down, this and towards me. Breathe in, breathe out, down, this, towards me. And relax. And I come back to the center, I follow. 3 to 4 times you can do this. Then you be there, just follow. It will want to move a bit in any direction. It's just the fascia unwinds. And then you be there. Very, very gently. At this point, if they want, they can lie down also. Thyroid, you can do it lying down or sitting. It doesn't matter. Hyoid is, the grip is, the movement is a little better sitting than lying down because while lying down, it's pulled up because the position of the tongue is towards the palate. So the hyoid is automatically pulled by the tongue in lying down position. And then you just be there. And you can retest. If you still feel that no, I feel one side is a little more tensed, you can repeat the technique. Yeah. You can do. That is also another way. You can ask for holding. While moving, it's a little easier to go with the out breath. For structures which move with the breath. For structures which don't move with the, like say if you are doing the functional for the femur, it doesn't matter so much. But when you are doing a liver or any structure that moves with the breath, with that, if you do it with the out breath, it's just easier.
So we did not practice this technique. It was just to demonstrate because we already know functional technique, right? Okay. So this was just to demonstrate the higher thyroid release. Okay. So now we move on to the laryngeal artery. So I need a model who wants to be. So we choose to treat right side because she has received all the treatment on the left and it's already way better, yeah? So I want it to come slightly sideways. Yeah? So for working on the laryngeal artery, we are first finding out thyroid at the level of C3. Yeah? So we are going to feel the bone sideways until we come at the end of the bone, the lateral part of the bone. Yeah? So we are going to feel. I still feel the bone, yes. Still feel the bone, you're not compressing. Huh? The bone can be easily felt. Yeah? Bone, yes. Bone, yes. Bone, no. So I know I'm on the lateral side of the bone, of the hyoid. Yeah? So I choose to treat this side. Yeah? So now I'm the lateral side of the bone. So the laryngeal artery is on slightly below the hyoid and it's deep. So how do you go deep? You wait. Yeah? You wait for the structures to sink in. So this is the lateral border of the hyoid. I'm going to go slightly below the hyoid and I wait, I sink in and I have a pulse. So the pulse is not as big as a common carotid pulse. So it's like few strands of hair. If I take it, you see, this is the diameter of the artery. Yeah? So it's very thin artery, but you feel the pulse because it's there. Now I'm on the artery, okay, so I use the left hand, yeah. So again, I'm on the bone. I'm not on the bone. That's a confirmation I'm on the lateral side of the bone. So I go below the hyoid now, okay. I go below the hyoid, I wait for the structures to sink in, yeah. I sink in, because the structure is deep, the artery is deep. And I feel a pulse. So I do not have to do any effort. I simply have to wait for the pulse to come to my hand. Yeah. Now, as usual, we follow the SCM border and we are on the medial border to find the common carotid artery. And I have both the pulse now. Okay. So I'm going to go inside the artery. So which artery is it? I go inside the common carotid artery. When I go inside, I receive the flow of the common carotid artery, and when I receive the flow, I get a listening. So in her case, the listening of the common carotid is going upwards, cranially, and the listening of the laryngeal artery is going in this direction towards the hyoid medially. Yeah? So I'm simply going to stay inside the common carotid artery and the laryngeal artery, and I'm going to follow the listening. So in her case, they're coming together, yeah? And I follow with my body because I am the artery now, yeah? So there's a torsion, I keep listening, I keep following the way the artery moves, yeah? Yeah? So now they want to go against each other. Now there's a stretch. So we are doing stretch induction. Yeah, we are listening and we are doing the stretch induction. It's not a mechanical stretch induction. Yeah. So see, I am bending my body because the artery is also really going down there. Yeah. And now there's a release. They come back to its original position. Yeah. And I do not feel any restriction, any pull from anywhere because it's more harmonious to my fingers. Yeah. And that's how you do the treatment. Okay. So I repeat again. Thyroid bone, we all know, we feel the bone. Bone, 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 no bone. Means I'm on the lateral part. Now from here, I know I have to go below the thyroid. So I come below the thyroid. I sink in, I wait, I wait, I wait. And I feel the pulse. So it's the pulse of laryngeal artery. We know how to feel the common carotid. We go inside the common carotid. There's a listening, stretch induction. Okay? Finally, axillary artery. So you do not poke. And you have to be mindful that the nails are not hurting. Yeah? So that's why you keep a tissue, a towel, whatever works. Thin enough to feel the structure. So you're going deep inside. You're waiting. You're making your way because you have to go to the humeral head, very, very deep. So you go, wait and feel the pulse. When that comes to your hand, then the other hand goes and grabs the belly of the apex minor. And you have to release through a stretch induction. So the axillary artery, the stretch, of course goes upwards because the artery goes as brachial artery, It doesn't go like that, downwards. So that's why upward stretch. And the muscle belly, you have to release it and see the fibers of the apex minor. So you're really fanning. That's why you're fanning your fingers. Yeah? You release and then release it 3-4 times until you have a listen. Listen and fall.
So the petrous minors we have to take caudally and cephalic also. We don't do like that. Like in general, we take it with the expiration. We take caudally and we don't have to.